can see that. Good morning, all. Welcome back to 8th edition of Kent Academics, that is Karnataka ENT Hospital Academic Program. Today, we have topic on approaches to lateral skull base. To start with part 1, that is the Translabyrinthine approaches. And Dr. Oshin Thomas, our Otology fellow, as well as junior consultant of Karnataka ENT Hospital and Research Center, she will be presenting this. Yes, ma'am, you can start now.
Good morning, sir, and good morning, one and all gathered here. So today's will be the first class of our series, Approaches to Lateral Skull Base. So let me take you to the presentation. So this is just an outline where we'll be seeing in the coming classes. So today's class we'll be discussing only translabyrinthine approaches, and in the coming classes we'll be seeing the transcochlear approaches, the middle cranial fossa approaches, the retrosigmoid approaches, and infratemporal fossa type A, B, C, D, and extreme lateral approaches. And there are also combined approaches of combination of these approaches, which we will be seeing in the coming classes. So first of all, how to decide on the choice of the approach. So the choice of approach is depending on various factors, like few I have enumerated here. One is size, then there is location, then the baseline hearing status of the patient, and the tumor type. So how does the size of the tumor decide the approach? So it is in literature it says that if the tumor is very small, and if the most important factor is the hearing status of the patient. So first, initially the approaches can be classified into two. One can be hearing preserving approaches, and the other one is where we will be not preserving the hearing. So if we have to preserve the hearing, then depending upon the size of the tumor, we can decide different approaches. So if the size of the tumor is less than 1 centimeter, and if it is extending only in the intracanaliculaar part of the internal acoustic meatus, then we can approach a middle cranial fossa approach. But if the tumor is too medially into the cerebellopontine angle, and if it is not coming into the intracanalicular area, then we can choose, and if the hearing of the patient is good, then we can choose a retrosigmoid approach. So that's what it says about the size of the patient. But if the size of the tumor is very large, like more than 2 centimeter, then irrespective of the hearing status of the patient, we might have to choose a translabyrinthine approach. So whatever we do, we will not be able to preserve the hearing of the patient. So that is the size and the location and baseline hearing status. Now, more about baseline hearing status. So we have to decide which hearing can be preserved and which hearing to sacrifice. So in the Atlas of Clinical Atlas by House, their lateral skull base surgery textbook, it is written, they have described a 50-50 rule. That 50-50 rule says that if the patient is having a 50 decibel of pure tone average, and if the patient is having 50%, greater than 50% of speech discrimination score, then such kind of hearing can be preserved. So that is the criteria which they are using. And when it comes to tumor type, so how does tumor type decide on the choice of the approach? So it is said that there are different tumors which are present in the cerebellopontine angle. So for most common tumor will be the acoustic neuroma or vestibular schwannoma, and there are other tumors like meningioma which are present. So depending upon the tumor type, meningioma, the tendency of the meningioma is to displace the tissue. Instead of invading the tissue, meningiomas will be displacing the tissue. So the chance of invading facial or cochlear nerves in cases of meningioma cases will be less. So there, the chances of preserving hearing will be more. So we will have to choose an approach which will preserve the hearing. But in cases of vestibular schwannoma, where already the nerves are involved, so there is no point in choosing a hearing preservation. So these are the most important criteria which will help us to decide which approach we have to choose. Now we will be discussing in detail about the translabyrinthine approach. So here what is shown in dark color is the translabyrinthine approach. We can see this is the external auditory canal, and here we have the internal auditory canal, and we can see the labyrinthine is sacrificed, whereas the cochlea is preserved. So if it is going through the cochlea, it becomes a transcochlear approach, which we'll be seeing in the later classes. Now here the picture shows Dr. William F. House. So he is known as the pioneer in cochlear implant surgeries. He is the one who invented the cochlear implant surgeries. So sir is also the famous person, the first person who has chosen Translabyrinthine approach for acoustic neuroma surgeries, and extensive surgical procedures were carrying on in the House Ear Institute. So here more than 5,000 acoustic neuroma surgeries they have conducted using Translabyrinthine approach, and there is a drastic decrease in mortality once they have started choosing the Translabyrinthine approaches. So before the Translabyrinthine approaches were used, the middle cranial fossa approach was more in prevalence at that time, and this duration it is during the age of 1960s. So that is Dr. William F. House. Now here in this picture we are showing the different approaches in one single picture. Here we can see this is the Translabyrinthine approach where we'll be going through the labyrinth. Then we can see here the Lateral labyrinthine where we are avoiding the labyrinth and entering the cerebellopontine angle. And here we can see the transcochlear where we will be the cochlea will be taken off. So that will be through the transcochlear. So that is transcochlear approach, and we have the suboccipital approach where we will not enter the labyrinth or the cochlea. So these are the various approaches. Now here is just a schematic representation of what we are actually going to see. So normally for any surgery where we'll have to just expose the internal auditory meatus, we will not need an enlarged approach. So, but when we'll have to address a tumor which is present in the cerebellopontine angle, then we will need a wide exposure. So that is what is shown us. That is shown us in green color here. The wide exposure which we are going to create, which we'll be discussing in the coming slides. Now the rationale of the study. This Translabyrinthine approaches, it gives a direct lateral access to the internal acoustic canal and the CP angle. So that is the most advantage of the Translabyrinthine approaches. So if we do not want to preserve the hearing, then this is the best access which will give us to which we can enter the internal acoustic meatus and the cerebellopontine angle. And in this approach, the entire facial nerve will be exposed from the brainstem to the stylomastoid foramen, and it gives excellent exposure, and it helps us to overcome all the anatomical limits, and there is no cerebellar retraction, which is another attraction of Translabyrinthine approaches. And another important point is they help in extensive bone removal around the structures, and this helps in retraction and without causing any much damage to the tissues. So these are the most important points of the Translabyrinthine approaches. Now, the cerebellopontine ankle lesions, when hearing preservation is not aimed at, we have already discussed that. That's when we use Translabyrinthine approaches. And the various tumors in the decreasing order of their frequency, the most common tumor which is present in cerebellopontine ankle is acoustic neuromas, which is around 75 to 90%. And then in the decreasing order of frequency, we have meningioma, we have epidermoids, and we have non-acoustic neuromas. Now, this is a picture which shows the classical ice cone appearance of the acoustic neuroma. So this is known as ice cone because the cone represents the canalicular part and the ice represents the brain part, the part which is coming into the cerebellopontine angle. So that is the ice cone appearance. Now I have chosen, next to this picture, we have an MRI which shows another ice cone appearance. So I have put this picture just to show you that all ice cone appearance, all tumors which has an ice cone appearance are not acoustic schwannoma always, because the MRI scan which shows another ice cone appearance is a meningioma actually. So how this meningioma actually differs from this acoustic neuroma. Here we can see a dural a dural extension, a dural tag, which is very specific for meningiomas and which is not seen in the acoustic neuromas. So that is how these meningiomas different from the acoustic neuromas. So this is just to show you that all ice cone appearance is always classical for acoustic neuromas, but it can also be seen in meningiomas, but they will be having a dural tag, dural tail. Now the contraindication of the surgery. If the ear in which the acoustic neuroma is present, if it's the only hearing ear, then we will not be using a translabyrinthine approach, because here the most important concern is to preserve the hearing of the patient. And then if the ear which is having the tumor, if it's having an ipsilateral chronic otitis media, then we will not adopt a translabyrinthine approach, because there are chances of transferring the infection from the mastoid or from the labyrinth and the mastoid into the sterile cranial cavity. So that's why we will this is a contraindication for using the translabyrinthine approaches. Now coming into the translabyrinthine approach in detail. Now first, the incision when we are putting, so incision starts 2 to 3 centimeters superior to the helix, and it comes posteriorly around 4 to 5 centimeters from the post-oral groove. Okay, we are putting a very wide incision just as to give us better exposure when we go inside. So that is the importance. Now here the picture shows that when we take a wider incision, okay, what are the structures? So here at this level we might have the linea temporalis, and here we will be having the sigmoid sinus. So, but even we are going far behind to have a better exposure. Now, once the flap is elevated, beneath we have the musculoperiosteum. Here we are putting a very big, thick T-shaped musculoperiosteal incision to raise that using a septal elevator. Now, once this is completed, we can fix the flap using sutures. We can use a thick silk sutures, mostly 2-serve sutures, to keep it in position. Now, once this exposure is made, this is because mostly we will not be able to maintain them using a mastoid retractor, and also mastoid retractor can come in the way during the operation. So fixing it using a silk suture will be giving us better exposure during the surgery. Now, once we have exposed the mastoid region where we have to start drilling, now we will have to go to the landmarks. First, we will have to identify the McEwen's triangle. See, this is the McEwen's triangle, just described as a line which is drawn parallel to the posterior ear canal, then which is a line drawn parallel to the linea temporalis, and a tangent which is drawn connecting to these lines. Now, this marks the landmark of the mastoid antrum. Now, our drilling starts from the keeping in view of the McEwen's triangle. Here you can see the first cut is just parallel to the posterior ear canal, and then we have the starting from the root of the zygoma along the linea temporalis. That will be the second line. Now, once we start drilling, we can see this slowly. Our the first place where we have two exposures, we open the antrum. Now, it is said that while we are starting drilling, only the antrum should be exposed. We should not make a wider additus, because later when we finish the procedure, when we'll have to use fat tissue to occlude it. So keeping the antrum, keeping the additus narrow will be helpful in preventing a CSF leak. So that is the most important point while opening the antrum. And the second important point is, the important landmark we will see is the lateral semicircular canal, which is the solid bond which is seen here. Now, once the lateral semicircular canal is identified, now the keeping lateral to the, if we are drilling lateral to the lateral semicircular canal, that means our facial nerve is safe. So here this is the region where the facial nerve is occurring. Now here we can see slowly we are exposing the tegment region, and also we are exposing the sigmoid region. Now, as we proceed the drilling, we can see the sigmoid sinus and the tegment plate are delineated, and And you can see the lateral semicircular canal is more, and we can see more prominent here, more visible here, and we can see the sinodural angle between these two structures. Now, as we proceed drilling, our next landmark where we'll have to reach is the posterior semicircular canal. So here we can see the lateral semicircular canal, the posterior semicircular canal, which is little more medial to it, and in the next stage we'll be seeing the superior semicircular canal. Now here we can see a complete mastoidectomy where we can see all extensive mastoidectomy where we can see the facial nerve, which is properly delineated. We can see the digastric ridge, which is a prominent landmark to show the vertical segment of the facial nerve. Then we can see the facial nerve taking a bend here. This is the second genu of the facial nerve, and we can see it is medial to the labyrinth, medial to the lateral semicircular canal. So always, if you are lateral to the lateral semicircular canal, the facial nerve is safe. Now, once this much exposure is achieved, now the most important part of the translabyrinthine approach is to expose the sigmoid region. Here we can see the sigmoid region. Now, when we are drilling along the sigmoid region, we should take care to remove the bone which is present behind us posterior to the sigmoid region. Now, this is important because if the sigmoid is lying anteriorly, or if we need a wide exposure, so we will have to remove the entire bone in the region, and we will have to retract the sigmoid posteriorly to get a better vision, to get a better access. So for that retraction, the entire bone above it and posterior to the sigmoid region has to be drilled out, taking very care. Now, once we are drilling the sigmoid sinus, we drill it to that extent such that only a paper thin bone, only an eggshell thickness bone is left behind. And slowly we can remove it either using a septal elevator or you can using a ronger. Now, when it comes to sigmoid drilling, there are two different techniques which are present in the literature. So one is the eggshell technique, which I have explained just now. The eggshell technique is making the sigmoid sinus, the bony plate over the sigmoid sinus, into very thin paper-like eggshell thickness, and just making small fragments, and slowly two ways are either we can remove the fragments bit by bit, and the other thing is once you have fractured the entire length in like eggshell, you can slowly compress it or retract it using a suction or a elevator or a septal elevator. So this is what is in the eggshell technique. Now, another prevalent technique which is present for sigmoid retraction is the Bill's Island technique. So this was advocated by Bill's house, where he said that a small island of bone is left on the prominent part of the sigmoid sinus, and the remaining all bones are drilled away. Now, the advantage of Bill's Island technique is it will give us a more protection when we're actually retracting it using a suction tip. So that is the Bill's Island technique. Now, when you are exposing, when you are exposing the sigmoid and when you are removing all the bone above the sigmoid, now another most prominent structure which is present is the mastoid emissary vein. So this is the anatomical location of the mastoid emissary vein will be posterior to halfway of the sigmoid sinus, which is seen here. So when we will have to retract the sigmoid sinus posteriorly, or if the tumor is very large, for better exposure, we will have to sacrifice the mastoid emissary vein. So when mastoid emissary vein has to cauterized, it is how it's done is we will have to burr the drill parallel to the mastoid emissary vein until a small tag is left and we can cauterize it. Now, while you are cauterizing it, the care should be taken. It should not be too close to the sigmoid sinus, as if it's close to the sigmoid sinus, it can create a hole in the sinus wall, which will be very difficult to manage later. So leave a few millimeters of mastoid emissary vein while you are doing this. Now, once the sigmoid sinus and the tegmen region are completely exposed, now next we should be approaching the labyrinth. We should be doing the labyrinthectomy. So here, in Mariusenna, it is said Mariusenna prefers to leave a small piece of bone, a small part of bone between in the sinodural angle. Okay, this part of bone, fragment of bone, will be preserving the superior petrosal sinus, which is lying in this direction. So it is said that if this bone is kept in place while we are doing labyrinthectomy, that will be more protective to the superior petrosal sinus. Now, when we are opening the labyrinth, it is opening in serial fashion. First, we'll be opening the lateral labyrinth, lateral semicircular canal. Then we'll be opening the posterior semicircular canal, and then we'll be opening the superior semicircular canal. So here we can see the labyrinthectomy done. And once the entire all the semicircular canals are drilled away, this is what we see here. And here we can see the area of the vestibule. Now, this is actually the subarcuate artery, which is found around in the midway of around in the center of the superior semicircular canal. Now, this is important as we proceed. This landmark is important as we move towards the drilling of the internal acoustic canal. Now, once this is done, once the labyrinthectomy is completed, slowly you can see this will be the appearance when the complete labyrinth is drilled away. Now, after the labyrinthectomy is done and slowly the vestibule is opened, then what we can do is then we can see the part of bone which we had kept earlier is removed, and you can see this is the direction of the superior petrosal sinus. Now, our next task will be to slowly remove the bone which is overlying the pre-sigmoid dura. It's also the posterior fossa dura. Now, slowly by retracting the sigmoid sinus, you can see as we proceed the surgery, the sigmoid sinus is retracted away using a suction tip. And slowly we are removing the bone fragments which is lying in the posterior fossa dura or the pre-sigmoid dura. Now, this is once we have completed this, our next landmark would be to know where exactly the internal acoustic meatus lie. So that is the most important. We should know where to look for the internal acoustic meatus. Now, this is the schematic representation. You can see the vertical segment of facial nerve. It is the genu, and you can see the horizontal segment of facial nerve coming into the acoustic meatus. Now, if you see carefully, you can see the orientation of internal acoustic meatus is just beneath roughly you can say that the orientation of internal acoustic meatus is just beneath the second genu of the facial nerve. And to be more precise, actually the longitudinal axis of internal acoustic meatus is actually parallel to the external auditory canal. So external auditory canal will be lying like this, and it will be the internal acoustic meatus will be parallel to the external auditory canal. Now, so according to this schematic picture shown here, so this will be the location of the internal acoustic meatus. Now, what we have to know is how much of the bone above and below should be drilled away without damaging the internal acoustic meatus. So for that, we should know the proper landmarks of the internal acoustic meatus. Now, for finding the proper landmarks of internal acoustic meatus, the most important one of the most important landmark which we can use, which we find, is Mike's dot. Now, this is a favorite question for post-graduation during their Viva examination. So what is Mike's dot? Now, Mike's dot is actually, it is a cribriform porus which marks the origin of the superior vestibular nerve. Now, if you trace the Mike's dots and go medially, so and it is also present on the medial wall of the vestibule. Now, this you can trace medially to reach into the internal acoustic meatus. So that is the importance of the Mike's dot. Now, here you have the Mike's dot, and so this will be the location of the internal acoustic meatus. Now, next thing you have to know is what are the landmarks of the fundus of the internal acoustic meatus. So just now we have seen most superficially or most laterally we have the medial wall of the vestibule marking the Mike's dot. Now, superiorly, what we have is the extent is earlier we have seen in the picture. This is the subarcuate artery. So superiorly, subarcuate artery marks the superiormost portion of the internal acoustic landmark for the internal acoustic meter. So all the bone above the subarcuate artery can be drilled away without any concern. Now, inferiorly, what we have is we have the jugular bulb and we have the cochlear aqueduct here. So this will be the inferior limit for the while we are drilling. So now drilling the bone above and below is known as creating a trough. Now slowly we can see in the coming pictures, we can see slowly the bone superiorly and inferiorly to the internal acoustic meatus is drilled away, and we can see the trough being formed. Now, while you are drilling, you should take care along every important structures. The drilling should be along their horizontal, along their longitudinal axis. So if you are drilling along the facial nerve, the movement of the drill should be in this direction. Now, since the internal acoustic cavity canal is in this direction, the movement of the drill also will be in this direction. Now, and another important point is always drill from medial to laterally, so that we will not damage any structure in the medial in the cerebellopontine angle region. Now, this is the direction of the drilling from medial to antral. And slowly we can see we are delineating the internal ISC internal auditory canal. We can see the superior bone and the inferior bone are slowly drilled away, and the trough is properly formed, and the bone above the internal acoustic meatus can be slowly removed. We can see here the bone around the internal acoustic meatus, only the dura is left behind. Now this ear was the right ear which we have discussed. Now, if it is in the left ear, it would be like this. This will be the tegment, this will be the sigmoid sinus, and this will be the vertical portion of the facial nerve, horizontal portion of the facial nerve, and the alignment of the ISC will be like this. So this is the vestibule. Now, medial to the vestibule, there is another landmark as we proceed drilling, which is the horizontal crust. Now, if we have studied in anatomy, there is a horizontal crust and a vertical crust and a transverse crust. So this we are seeing here. Here you can see a schematic representation of the Bill's bar and the transverse crust. So Bill's bar is a crust which divides the facial nerve from the superior vestibular nerve. And here you can see the transverse crust which divides the inferior vestibular nerve from the superior vestibular nerve. So that is what is shown here in the picture here. Here you can see vestibule. Beneath that you have the horizontal segment, the horizontal crust. The horizontal crust is a crust which divides the inferior and the superior vestibular nerve. Now again, that is shown here more nicely. You can see the facial nerve coming from the vertical part. It is taking a turn here and coming into the canal. You can see how anteriorly the facial nerve is lying in the canal. Now, this anterior location of the facial nerve is actually a boon, because while we are dissecting the inferior and the superior vestibular nerve, there is less chance of since due to the anterior location of the facial nerve, there are less chance of damaging the facial nerve. Now, we have already seen that this is the transverse crust and this is the vertical crust. Now, again, same thing shown here. To understand it more nicely, we have the facial nerve. Between the facial nerve and superior vestibular nerve, this will be the location of Bill's bar. Now, between the superior and the inferior vestibular nerve, we have the horizontal crust. Now, here, this is the picture where the dura is opened. Now, in the actual surgery, once you are delineated the IAC, then you will have to get a more view on the facial nerve, you will have to actually remove the inferior vestibular nerve. Now, inferior vestibular nerve is seen here, slowly removed. And next we go towards the superior ambulary nerve. Once this is also removed, you can see beneath lies the facial nerve. So that is the landmark we are looking for. Now, once this much landmarks we have achieved, the next most important point is to open the dura and enter the cerebellopontine angle. Now, if this area would be more familiar if we tell it as Trotman's triangle. So what is Trotman's triangle? Trotman's triangle, it is the triangle which is superiorly demarked superiorly by the superior petrosal sinus. Here we can see the superior petrosal sinus, and posteriorly by the sigmoid sinus. Here we can see the sigmoid sinus, and anteriorly by the solid angle, which is found by the 3 semicircular canals. So this would be the region. Now this is the area. This triangle is known as the Trotman's triangle. Now Trotman's triangle, it's also a favorite question for postgraduates. What is Trotman's triangle and what is its significance? Now Trotman's triangle, it is a triangle which helps in entering the posterior cranial cavity. So here we have what we are seeing is the posterior fossa dura. Once we open it, we are entering the posterior cranial cavity. Now another important landmark which we have to mention is the Donaldson's line. Now here what you are seeing is the here we are seeing in the endolymphatic sac here. Now Donaldson's line is a line which is drawn along the lateral semicircular canal, bisecting the posterior semicircular canal, and anteriorly, inferiorly, and medially lies the endolymphatic sac. So that is the importance of the Donaldson's line. Now once you are opening the dura, you can see once you have this, the dotted line shows the area which we opened the dura, and once we have opened the dura, we can see the tumor lying here, and slowly the dura on the IAC, internal acoustic meatus, is also opened, and the tumor can be delineated slowly from the facial and the cochlear nerve. And once the surgery is done, we will have to close it with the abdominal fat. So even before the beginning of the procedure, we will have to harvest the abdominal fat required for the surgery. So there are certain things which we have to keep in mind while we are taking the abdominal fat. So usually the left side of abdomen is preferred while we are taking the fat. So this is just to avoid misunderstanding with the appendicectomy scar. So that's why if you are taking an abdominal graft, better choose the left part of the abdomen. And next, once the abdominal fat is harvested, they are actually made into long strips, and they can be preserved in bacitracin solution, and they can be covered till we'll have to use it for closing the fossa, closing the cavity. Now while you are closing, here you can see the abdominal fat used to closely obliterate the cavity. Now while you're obliterating the cavity, some surgeons prefer the abdominal fat is placed in the adductus, and few surgeons prefer they will open the adductus, they will remove the incus, and they will expose the facial recess, little bit of posterior facial recess, and they will obliterate the eustachian tube. So that is also to prevent all kinds of CSF leaf. Now this procedure is also used. Now once we have used the abdominal fat and then obliterated the cavity, then we can put back the flap and we can suture it. Now there are certain pearls and pitfalls which we have to keep in mind. Now one thing is extensive bone removal over the middle fossa dura and posterior to the sigmoid sinus to expose the posterior fossa dura is the fundamental step in the enlarged approach. And sigmoid sinus has to be completely uncovered, which we have already seen, and utmost care should be taken not to injure the nerve during drilling to open the vestibule. Now these are the important things. Now here we can see exposure is the key to any surgery. So likewise here all our efforts are first to make a good exposure. So all the drilling posterior to the sigmoid also is keeping in mind that we can retract the sigmoid sinus so that it doesn't come into our view and it gives a good exposure. Now another important point is we should not miss to drill away the bone between the sigmoid sinus and the jugular bulb. So that is another important point to be kept in mind. Now sometimes we'll have a large sigmoid sinus, which we have already seen. For such kind of sigmoid sinus, they require a more we have to almost drill around 2 centimeter posterior to the sigmoid sinus so that we can retract it completely. Here you can see a large sigmoid sinus which has been retracted completely. So while we do that, sometimes we'll have to sacrifice the mastoid emissary vein. Now another important structure which we have to keep in mind during this approach is high jugular bulb. So here we can see the sigmoid sinus is retracted, but the jugular bulb is in its normal position. But in some cases, jugular bulb can be very high. It is coming towards the internal acoustic, internal auditory canal. So when it comes to the internal auditory canal, there are high chances causing a jugular bulb injury while we are drilling. So in such cases, what we have to do is we have to expose the entire bone, axial thickness. We have to expose the entire bone. We can use a large septal elevator and you can retract it inferiorly. And you can see, we can fix it using a surgical and bone wax. And this will keep the high jugular bulb in place. Now, another small tips which we have to keep in mind while using this approach is, one is the dural tear. So when you are proceeding drilling, if at all a dural tear happens, so it is said that you can use the aluminum paper which comes along with the suture. You can cut a small portion of the aluminum foil and you can place it over the dura and proceed the surgery. Now, what if it's a small sigmoid tear? If it is a very small sigmoid tear which can be held using bipolar cautery, then use a large tipped bipolar cautery, keep the setting to the lowest possible, and then you can hold the two lips of the sigmoid tear and you can cauterize it. Now, if it is a medium sigmoid tear, then we will have to use a surgical and over it we'll have to give pressure using a cottonoid. Now, if it is a very large sigmoid tear, then you might have to suture it. Now, coming to the other pitfalls where we can hamper is, one is the exposure. If we don't get an adequate exposure, and also while opening the dura, we should be, utmost care should be given, respect should be given to the tissue. Also, the next thing is, while closing, we should take care, it should be watertight. While using the abdominal fat, there should be a watertight closure so that there should not be any CSF leak. Now, we have discussed all the translabyrinthine approaches in detail, and there are numerous advantages for this. First is, there is a positive lateral identification of the facial nerve at the fundus of the IAC. So we will never miss the facial nerve. So once it is in the vision, there are high chances of preserving the facial nerve. Second thing is, in all other approaches which you will be studying, there will be a cerebellar retraction. So in this approach, there is not much cerebellar retraction, which is another advantage. And the third point is complete exposure of the internal auditory canal for tumors that extends into it. So full exposure of the internal, this is the best technique which will give us the full exposure of the internal auditory canal. And if there is a post-operative hematoma, then reoperation is very easy and fast, because the sutures have to be cut, then the fat has to be removed and the hematoma can be evacuated. So even in post-operative complication, this approach is very helpful. Now, there is excellent exposure of the CP angle. And another is, CSF leak is very less when compared to other retromastoid approach. Now, there are also other advantages, like, there is, first, we have already discussed, there is constant visualization of facial nerve. And the other thing is, there is reduced risk of air embolism. Now, in certain cases where, like in suboccipital approach, sometimes the patient might have to be in sitting position while during the surgery. Now, this approach, there are high chances of air embolism, but in translabyrinthine approach, the patient will be comfortably lying on the table and the chances of air embolism is very less. It is the most surgical approach. Most of the surgical approach is extradural. We can see while the entire drilling is happening, the dura is not opened. So the entire most of the surgery approaches extradural, and there's less trauma to the brain. And since we are extradural always, there is decreased spread of bone dust into the CP angle. And it is also less likely to injure the facial nerve because of its anterior position. And also, when compared to other approaches, there is less headache, less neck pain and stiffness compared to the suboccipital approach. Now, these are the advantages. Now, when we have discussed all the advantages, the most disadvantage of this procedure is there is a total ipsilateral hearing loss. So if there is any chance for preserving the hearing of the patient, we should not be choosing this approach. Now, and another thing is, there is inadequate exposure of the tumors extending far anteriorly into the prepontine cistern. So here we are not getting a good vision towards the prepontine cistern. And the third thing is there is no inadequate exposure of the lower cranial nerves and medulla. And also the tumor with caudal extension into the lower clivus cannot be totally removed. So these are the advantages of the translabyrinthine approach. Now, all this time we have been discussing about the translabyrinthine approach. Now, what if our tumor is having a more apical extension? So in such kind of cases, we will have to choose a transapical extension of the enlarged translabyrinthine approach. So here is the first procedure we have seen. In the normally when we are exposing the inner canal, you'll be drilling only 180 degree along the internal acoustic meatus. But in the enlarged translabyrinthine approach, we had exposed 270 degree of the internal auditory meatus. Now, in the transapical extension of the enlarged translabyrinthine approach, we will have to go more extensively behind the internal acoustic meatus. So it will become a 220 degree or a 360 degree. So the rationale is the anterior extension of it is an anterior extension of the enlarged translabyrinthine approach, and it will be 320 degree circumference exposure in type 1, and it will be 360 degree exposure of the entire circumference of IAC in type 2. Now here we are this is a schematic representation showing the entire transapical extension of the enlarged translabyrinthine approach. Now indication, same as we have discussed earlier, when hearing preservation is not aimed, that is the most important fact. Then the other indications are large and giant acoustic neuromas with anterior extension into the prepontine cistern. So we'll have to use a type 1. Now, if it is a large posterior surface of the temporal bone meningioma, which is centered on internal auditory canal, then we will have to and it has a significant anterior extension, we will have to use a type 2 approach. And also small tumors with marked anterior extension. So all tumors which is having anterior extension, we'll have to use a transapical extension. Now, again, even though it will give a more anterior extension, it also has its limitations. So the first thing is there is huge petroclival meningiomas, which is towards the clivus, cannot be approached using this transapical extension. And this approach does not offer adequate exposure to the prepontine cistern. So these are the limitations. And here you can see we have made how we proceed from the translabyrinthine approach towards how we are proceeding for the transapical extension. Here you can see the internal acoustic meatus is drilled, more bone is drilled away, making a 320 degree extension. You can see both the superiorly and inferiorly. And extensive bone removal is still seen. Still we can see some bone which is lying behind. So for removing that, we can do the whole contents of the internal auditory canal, which can be pushed inferiorly, and the behind bone can be removed. So this gives us a total 360 degree exposure, removal of the bone, and that will help in the removal of the tumors which are having anterior extension. Now here you can see the whole contents of the canal are displaced inferiorly, and we can see the bone is removed. Okay, and that is what is shown here. The entire content of the internal acoustic meatus is pushed inferiorly, and the bone behind is drilled away. So in one slide, they are showing all the different types. Now this is the displacement of the AM bundle, the acousticofacial bundle, and the entire dura is the entire anterior region of the dura is exposed. Now once the dura is opened, this is what we actually see in the cerebellopontine angle. So this is the AF bundle. Now just beneath the AF bundle, we'll have the trigeminal nerve, which will also get a good exposure to the superior cerebellar artery. Now here we can see when the AF bundle is little bit pushed inferiorly and the trigeminal nerve is pushed superiorly. So behind that, we'll get a good view to the basilar artery. Now this is the pons which is shown here, and here we have the basilar artery. Now again, the trigeminal nerve is pushed. Here we can see the superior cerebellar artery. Okay, the trigeminal nerve is pushed inferiorly, and we can see the superior cerebellar artery. And slowly, if you extend the tendorium, beneath that you will be seeing the position of the posterior cerebral artery. Here we can see all the structures, and also we can see the oculomotor nerve here. Now, with the total retraction inferiorly and superiorly, this is actually the entire contents of the cerebellopontine angle, which can be observed using enlarged translabyrinthine approach with the transapical extension. Again, this also has its pitfalls, because the transapical drilling should always be done with a diamond burr and taking extreme care not to injure the facial nerve. And the usual trick is to place the suction irrigator between the drill and the nerve to afford protection. This is a very simple trick which is used by most of the skull base and the otology surgeons to protect the facial nerve. So we can keep the suction irrigator between the drill and the nerve can be protected. And next is care should be taken while drilling the petrous apex superior to the internal artery canal. So here lies superior petrous sinus. So more care should be taken while you are drilling superior to the internal acoustic canal. And if it is a giant tumor causing a very high intracranial pressure, then what can be done is the dura always usually bulges. It hinders the access. So in such cases, the dura can be opened first to allow the drainage of the CSF. Okay, and with the resultant release of pressure and shrinkage of dura, you can continue the drilling. So these are small pitfalls and pearls which you will have to adopt. Now, another thing is, when particularly in far anterior tumors, the facial nerve is markedly displaced anteriorly. So transapical extension allows much better visualization of the nerve. And also using this approach, we have abandoned the transotic approach for anteriorly located tumors and limits its use only to cases of concomitant cochlear invasion or vertical internal carotid artery involvement. So since it gives the translabyrinthine approach gives some more anterior exposure, we can prevent going to the drilling out the cochlea. So that is the another advantage of this transapical extension. Now here we have already seen many advantages. It allows better control of the trigeminal nerve up to the Meckel's cave, and the abducens nerve, the prepontine cistern, and the basilar artery is in vision. It allows better visualization of the facial nerve, particularly in large or anteriorly placed tumors, and it allows removal of the dura of the anterior wall of IAC, which might involve the meningiomas. So these are the advantages of the transapical extension. And of course, it has disadvantages, because for transapical extension, the first disadvantages, you'll have to take an extra 15 to 20 minutes of operative time. And we are actually working inside the cerebral cavity. So the chances of infections are more. And the next thing is, theoretically, there is more risk to facial nerve during drilling, but on experienced hands, such cases may not happen. So that's all regarding the translabyrinthine and the extended transapical approach. I hope it was useful. Thank you so much.